So the reason we wanted to lay this out fairly clearly is this is obviously a difficult decision, which is the reason the CMOs were asked to take a view on this. And in all of what I'm about to say, I want to start from the first principle of medicine, which is it is always about balancing risk and benefit. And if by doing something, the benefits exceed the risks compared to not doing something, then it is a sensible thing to do. And if it's the other way around, then it is not. That basically is central to all of medicine. There is almost no area of medicine which is risk-free. So what you're always trying to do is balance risk against benefit. And that's true in this decision as all other ones. When it comes to recommending vaccination for children 12 to 15, there are several stages we've gone through already before we come to what we've said today. The first is that the independent regulator, MHRA, has examined the data, and their judgment was that in all those aged 12 and above, for the messenger RNA vaccines, shall give us a shorthand as Pfizer and Moderna, that they authorized these for use and gave them a license at this stage in time on the basis of their assessment of the efficacy, how effective they are, and the side effects as understood from trials to date. So that's where they are, and of course they continue a process of continuing to look at both efficacy and side effects in due course. JCVI, the Independent Scientific Advisory Committee, then took that on, and they've given two very important, in a sense, adjacent views about the use of these vaccines in children and young people. The first of which is they have given a clear recommendation that for children and young people over the age of 12, who are themselves in a particularly high-risk groups, and they've given a list of those groups, or, importantly, living with people who are immunosuppressed, they recommend that people 12 and above have 2 vaccines with messenger RNA vaccines. So that is already a decision that JCVI has taken and that others have followed. Secondly, they have recommended that young people aged 16 and 17 get a first dose of vaccination, and that dose of vaccination is given to or is offered to everybody. And that supplements the 2 vaccines that are offered to everybody 18 and above. So that is the current situation. On the situation of looking at children and young people aged 12 to 15 who are not in the high-risk groups, so their view on the high-risk groups stands, so what I'm about to say refers to everybody else. They looked at the risk and they looked at the benefit, and their view was that the benefits exceeded the risk, but that the difference between these two was, in their words, marginal. And that is because the risk is small and the benefit is small. The benefit exceeds the risk, but by a small margin. And by their usual assessment in terms of individual risk-benefit, their judgment was they wouldn't normally, in this situation, recommend the rollout of a vaccine. But to be clear, they did say that benefit exceeds risk. And I think it's important to start with that principle. They also, however, and very atypically, made a suggestion to ministers that because there were also wider issues at stake for children and young people of this age, that the ministers consulted the 4 chief medical officers. And that is what's happened. So ministers were following a suggestion of JCVI that the wider situation was that. So that's where we got to in terms of why CMOs were asked to do this. It was following a suggestion from JCVI. Now, in doing this, the chief medical officers have taken several principles which I want to lay out. And I realise this is a long preamble, but I really want people to understand this. The first principle is that we will only consider, and we have only considered, risks and benefits that actually accrue to children and young people 12 to 15. So we have not considered any benefits that might accrue to adults or anyone else. This is purely about children of the age group we're talking about. That's a first really important starting point. The second important starting point was we did not intend to, and we fully agree with, the assessments of MHRA as the regulator, independent regulator, and JCVI as the scientific advisory group. So we've not gone over any of their data again. We've simply taken it as read And they've done a very useful table of risks against benefits for those who want to look at the numbers, and Professor Lim can talk about that if people are interested, but we've taken their numbers as read. The third thing we decided was we wanted this to be a central view, as best as we could assess it, of the medical and scientific and public health professions. And to achieve that, in addition to looking at data, which we have done independently outside the stuff that JCVI's looked at, we also consulted the presidents of the Royal College of Paediatrics and Child Health, of the Royal College of General Practitioners, of the Faculty of Public Health, and of the Royal College of Psychiatrists, looking at issues around mental health. And we additionally have consulted leaders in public health from around all the regions of England and Scotland, Wales and Northern Ireland. So we've tried to have a very broad view about where things come from. And I suspect when professional colleagues respond back, they will fully accept that what we're trying to do is get a middle view of where we think the profession is. So this is not an outlier view, this is a middle view of where we think the profession is at this point in time. So that's the preamble, and I just want to lay that out so that people understood the process. Now, in terms of our judgment, the starting point, of course, is JCVI saying there is an advantage, but it is marginal. So there is only justification for rollout a universal offer if the risks and benefits on the additional things we can look at are actually material. And in particular, we looked at education, which is clearly central to the consideration of anything for children, young people, 12 to 15. And we also looked at operational issues. For example, how does this interfere with flu vaccination and other areas? We didn't go back over the clinical ground because JCVI has already covered that, and we fully agree with their assessment. And when we did this, we had some extremely powerful evidence, both numerically, but also from our colleagues working particularly in areas of deprivation around the country, and also general practitioner colleagues, and also colleagues from mental health. And they all made the same point, which is the disruption in education that has happened over the last period since March 2020 has been extraordinarily difficult for children and had a big impact on health, mental health, and long-term public health. And that this is most apparent in areas of deprivation. They were very clear on that. So the question for the CMOs on the educational side, accepting that advice, which completely concords with all the data that we have, was will vaccination reduce the disruption and therefore reduce these very significant negative impacts? And our assessment is the answer to that is yes. It will reduce educational disruption. We do not think that this is a panacea. This is not a silver bullet. It's not a single thing that on its own will do so, but we think it is an important and potentially useful additional tool to help reduce the public health impacts that come through educational disruption. So that has been really critical in our decision making, and this is true whether we're talking about individuals' physical health, individuals' mental health, or the long-term effects that a disrupted education can have on people's life chances. So that's very much where a lot of our discussion lay. And we did think that on balance it was likely to improve things. And we looked at the negative sides, and there are some issues around operational issues, as I say, particularly around vaccination. But our view was the benefits that this is likely to lead to in terms of reducing impacts on education outweighed those negative areas. So overall, our assessment is combining the marginal but assessed benefit that JCVI made at an individual level, taking on board additionally the issues around education. Our view was the benefit exceeded the risk to a sufficient degree that we are recommending to our ministers in all 4 nations that they make a universal offer, and I want to stress the word offer, of vaccination to children 12 to 15, in addition to the ones that have already been given it. So that is our current advice to ministers, and it is now with them to decide in each of the 4 nations how they wish to respond. Just want to add one additional thing, and then I'd like to ask Dr. Rain and Professor Lim to add from their sides and then turn to my CMO colleagues. And that is that we are really clear that it is very important that this balanced decision of how the benefits exceed the risks, but the fact that these are closer than they are in for example, people in their 50s, 60s, 70s, are communicated fairly and properly to children, young people and their parents, so that they can make a considered decision. That's very much something we think is important, and that children, young people and their parents are supported in the decisions they make, and there is no stigmatization of people either for accepting or not accepting vaccination. We do think this is really critical. And our colleagues in general practice and in paediatrics and child health will work with colleagues in public health to try and help make sure that that balance of understanding is presented in an appropriate way that actually makes sense and is comprehensible by people at different ages about what's going on. So that is our overall advice, but that important rider at the end.